Welcome to my series on clinical case scenario. In the first clinical scenario today, I shall discuss the case of a 41-year-old female patient with abdominal pain. The patient is a 41-year-old female who presented with a right upper quadrant pain of the abdomen for 1 week. It was a dull pain, initially mild but increased in severity over the days before admission. This was accompanied by yellowness of the eyes, dark urine and generalized itchiness of the skin. She had low-grade fever but no urinary and bowel symptoms. She also complained of mild vague epigastric pain for the past 3 weeks and she has been feeling unwell with loss of appetite and nausea but no vomiting. She had been on oral contraceptives for the last 2 years. She had an ovarian cystectomy done 2 years ago and no other surgeries. She is not a diabetic or hypertensive and there's no family history of similar illness or malignancy. On examination, she looked ill. She was dehydrated and face flushed. She was febrile with a temperature of 38 degrees Celsius and deeply jaundiced but no pallor. Her heart rate was 96 per minute, BP 100/62 millimeters of mercury, and a partial arterial oxygen saturation was 97% on room air. Her abdomen was flat and mildly tender in the right upper quadrant and epigastric regions. There was no guarding and the rest of the abdomen was soft and non-tender. The liver, spleen and gallbladder were not palpable and there were no masses palpable either. No signs of chronic liver disease was evident. Okay, these are the questions for the students. There are 5 questions here. You please go through these questions, try to answer them, and before you look at the answers that are given up to this. Okay, based on the history, the important or significant points in the history are highlighted in blue. For 41-year-old female, 1 week history of RAC pain, initially mild and progressive, then there's yellowness of the eyes, dark urine, itchiness and fever. Okay, she also has got similar symptoms, epigastric pain for the past 3 weeks, and she's on oral contraceptive and ovarian cystectomy done 2 years ago. Okay, now let's analyze the symptoms of this patient. She's the chief complaint. Okay, we know she's a 41-year-old female patient with a history of right upper quadrant pain for 1 week. Okay, also she has got fever with associated pain. She has got fever and yellow discoloration of the eyes, dark urine and itchiness. Okay, which are all signs and features of obstructive jaundice and Charcot triad. Besides that, she has been not feeling well for the last 3 weeks with loss of appetite, epigastric pain, and also she has been on oral contraceptives. In the relevant negative symptoms, no bowel urinary symptoms, no medical illness and no vomiting. And we want to know whether the fever is associated with Chills or Rigors. Now let's see the possible diagnosis from the history. Okay, the patient is a case of obstructive jaundice in a 41-year-old female for 1 to 3 weeks of duration. The pain is not so severe, associated with fever, and we are not sure whether there's chills and rigors. Patient has a history of oral contraceptive pills and has been feeling unwell for the last 3 weeks with severe loss of appetite. No vomiting, no medical illness, no bowel symptoms or urinary symptoms. So from this history, the most likely diagnosis will be acute cholecystitis. CBD stone with cholangitis, acute pancreatitis, cholestatic jaundice due to the oral contraceptive pill, hepatitis, bile duct strictures, periampullary tumor, and carcinoma head of pancreas. From the age and the short onset, these last two, periampullary carcinoma and carcinoma head of pancreas, are very highly unlikely. On examination, she looked ill. She was dehydrated and face flushed. She was febrile with a temperature of 38 degrees Celsius and deeply jaundiced but no pallor. Her heart rate was 96 per minute, BP 100/62 millimeters of mercury, and her partial arterial oxygen saturation was 97% on room air. Her abdomen was flat and mildly tender in the right upper quadrant and epigastric regions. There was no guarding, and the rest of the abdomen was soft and non-tender. The liver, spleen, and gallbladder were not palpable, and there were no masses palpable either. No signs of chronic liver disease was evident. Okay, what are the issues that we can derive from the examination? The positive findings are she has got fever, but we are unsure whether she got chills and rigors together. She is deeply jaundiced, okay, suggesting the cause must be something to do with the biliary system. There's only mild tenderness in the right hypochondrium and epigastric region. Okay, and then she has got tachycardia, and the blood pressure is quite normal. As for the relevant negative findings, there's no pallor, there's no guarding, rest of the abdomen is quite soft and non-tender, the liver, spleen are not palpable, and the gallbladder is also not palpable. Now, with the findings that we have at hand, let's look at a possible diagnosis in this patient. Okay, here is a young lady with deeply jaundiced for a week, with fever and feeling unwell for about 3 weeks. There's mild epigastric and right hypochondrial tenderness, and with high fever. All these three features suggest that she may be having some form of infection of the biliary tract due to obstruction. The negative sign is there's no guarding, which indicates that there's no severe inflammation of the gallbladder, and also the absence of organomegaly, especially gallbladder, is against a diagnosis of a tumor obstructing the bile ducts. So this leads to a condition of obstructive jaundice with Charcot triad, short history, and high fever. And the most likely causes or diagnosis in this case will be an obstruction of the CBD by a stone causing obstructive jaundice and complicated with ascending cholangitis. Bile duct strictures may be a differential diagnosis. So is acute pancreatitis, which can also cause obstructive jaundice. But the pain in this patient is not severe enough to support a diagnosis of acute pancreatitis. So at the end, after the history and the physical examination, we have come to a clinical problem of obstructive jaundice with ascending cholangitis as the main problem that this patient is having. And what is the most common cause will be gallstones. Whether this patient has gallstone or not, which has to be determined by some investigations. Okay, and these are the differential diagnoses at this stage: bile duct stricture,
cA head of pancreas, cholangiocarcinoma, and periampullary carcinoma. Okay, the last three, these three cancers are highly unlikely to be in this patient, but it's still a remote possibility. It is unlikely because of the acute onset and the the patient's age of 41. So the most likely diagnosis will be a CBD stone with obstructive jaundice and cholangitis. Okay, now we come to the questions. What are your differential diagnoses in this patient? As I've already said, bile duct strictures, carcinoma head of pancreas, cholangiocarcinoma, periampullary carcinoma, and cholestatic jaundice, oral contraceptive induced or estrogen induced cholestatic jaundice. Name the investigations for this patient. First, I will do the routine investigations as baseline, which will include a full blood count, renal profile, urine analysis, and a specific enzyme, serum amylase, to rule out acute pancreatitis. In the full blood count, the important thing will be a leukocytosis, increased total white count, which will suggest a diagnosis of acute cholecystitis and may be also cholangitis. For the liver function test, which is very more specific for this patient, we will look into the bilirubin, the conjugated and unconjugated, will given as confirm the diagnosis of obstructive jaundice. Alkaline phosphatase will also help to determine whether it's obstructive or non-obstructive. The AST and ALT are important enzymes that must be done if it is to diagnose acute hepatitis as a possible cause, and of course the albumin level. Coagulation profile is an important investigation for this patient with deep jaundice. Okay, and among them included will be the prothrombin time, the clotting, and bleeding time. The ultrasound scan is the most important imaging investigations that is most useful in this patient. It will rule out gallstones, it will rule out acute cholecystitis and possibly biliary colic. It can also show dilated common bile duct or the biliary ducts to indicate that there's some form of obstruction. And in a small percentage of cases, if the stone is big enough, it can also detect stones in the common bile duct. Then at the same time, it can give you an overview of the head of the pancreas to see whether there is any tumors, and also the liver, there are any additional infective focus within the liver, such as liver abscess. After the ultrasound scan, what we have is a CT scan or ARCP. Which comes first? ARCP will depend on what we see on ultrasound. If there are features to suggest there is some form of obstruction to the CBD, then we can go straight to an ERCP. Okay, to diagnose the cause of the obstruction and also the patency of the CBD, stones in the CBD, and if there are stones, then it can be removed through the endoscopic procedure itself. Okay, this third question, ultrasound done showed a stone in the lower end of the CBD. What other features will you look for in this ultrasound? Okay, this is the ultrasound picture showing a stone here and the CBD. It shows a dilated common bile duct. Okay, common bile duct is usually less than 6 millimeters in diameter, and anything more wider than that is considered dilated. So in this case it's dilated. Then it can also show the extent of dilatation, whether it extends into the liver and the intrahepatic ducts, suggesting that it's a long-standing obstruction. It can also show signs of tumor mass in the head of the pancreas as causing obstruction. If it is acute pancreatitis, you may be able to see an enlarged pancreas, and also lesions in the liver can also be detected by the ultrasound. Then this is an ERCP film which we do. Since we have done this, there's a stone and that's dilated, and then the ERCP will be the next line of investigation for this patient. We'll proceed with an ERCP. Actually, it is quite an urgent investigation for a patient who has got an obstructed biliary duct with a stone. Okay, we demonstrate the stone and also do a sphincterectomy and extraction of the stones if the patient is fit enough to be done at the same sitting. So after these investigations, ultrasound and CT scan, together with the clinical picture, we come to the final diagnosis of choledocholithiasis with obstructive jaundice and ascending cholangitis.
Okay, the next question, question number 4, describe the subsequent management of this patient. Okay, with the diagnosis at hand, the first phase of the treatment is called the preoperative, which consists of medical resuscitation of the patient. This has got three main components of this phase. First is the IV fluid and electrolyte balance, which has to be corrected. Adequate fluids and electrolyte must be given to the patient before the op. Secondly, adequate antibiotics must be started as soon as possible. Normally, a cephalosporin plus metronidazole will be the ideal combination to begin with. Thirdly, the coagulation disturbance in obstructive jaundice must be corrected as soon as possible before any interventional procedures can be done. And this consists of the giving of IV vitamin K at regular intervals as soon as possible. Once this resuscitative phase is completed and the patient is stable, then we look at the second part of the treatment, which is the interventional endoscopy or surgical procedures. This consists of ERCP. The interventional component is the ERCP, sphincterectomy, and extraction of the stone with or without the placement of a biliary stent. If the patient has got concurrent gallstones in the gallbladder, a laparoscopic cholecystectomy is undertaken if the patient is fit. Otherwise, it has to be deferred to a slightly later date. If for some reason the endoscopic procedure cannot be done or is not available, then open exploration of the CBD and removal of the stone with the placement of a T-tube has to be done as soon as the patient is stable.
The final question is, what is Charcot's triad and Covius law? Charcot's triad consists of jaundice, pain, right hypochondrium, and fever, like in this patient. She came in with all the features of the Charcot's triad. Charcot's triad is a feature of cholangitis, okay, ascending cholangitis. It's not necessary for cholangitis, every case of cholangitis, to have this triad, but if it occurs, then it gives weightage to the diagnosis of cholangitis. Okay, and classically these symptoms are intermittent. So intermittent jaundice, intermittent pain, and intermittent fever. And this triad, if it occurs, highly suspicious of cholangitis. Okay, so any patient with jaundice which comes with these features should be treated very aggressively and with great urgency. Cuvier law states in the presence of jaundice, an enlarged gallbladder is unlikely be due to gallstones. Okay, so in this patient, it's unlikely to be due to gallstone as the cause of this patient. The gallbladder is not distended, so it is likely to be caused by gallstones. This may be explained by the observation that the gallbladder with stones is usually chronically fibrous and so incapable of enlargement.
Now let's go into a cholangitis a bit more detail. Now, cholangitis refers to the infection of the bile ducts. Okay, bile ducts which consists of the right and left hepatic ducts, common hepatic duct, common bile duct, and the ampulla. Okay, and this infection is usually due to some form of obstruction at the lower end of the bile duct. Okay, for example, a lesion here of stone or some other sort of obstruction. And this obstruction results in dilatation of the ducts proximal to it. And this dilatation leads to bile stasis, and bile stasis predisposes to bacterial infection. And this is known as cholangitis. Some people call it ascending cholangitis because the infection ascends from the duodenum upwards into the bile ducts.
Okay, next, cholangitis refers to the infection of the biliary tract. It is associated with high mortality and morbidity when left untreated, and therefore is an important condition to recognize and manage aggressively and with great urgency. Okay, so infection of the biliary tract, cholangitis, is very serious illness. It is caused by a combination of biliary outflow obstruction. Okay, there's an obstruction of the biliary outflow and superimposed biliary infection. The infection is usually due to the stasis of fluid, stasis of bile, combined with the elevated intraluminal pressure, allows bacterial colonization of the biliary tree. And what are the causes? Any condition which causes occlusion of the biliary tree has the potential to cause cholangitis. However, the most common causes are gallstones, far by the most common gallstones. A stone impacted or passing through the lower end of the CBD can precipitate obstruction and subsequent infection. These days, ESCP is becoming another cause of cholangitis due to introduction of infection into the biliary ducts by ERCP procedures, and this is an iatrogenic cause. Other causes are cholangiocarcinoma, ampullary carcinomas, and rarer causes include pancreatitis, especially acute pancreatitis, primary sclerosing cholangitis, ischemic cholangiopathy, ischemic of the bile ducts, biliary ducts due to some cause, and parasitic infections, which are not so common these days. It's important to know that the most common infective organism implicated in cholangitis are E. coli, Escherichia coli, which accounts for 27% of the infections, Klebsiella species for 16%, and Enterococcus for another 15%. Okay, these are all gram-negative organisms. In addition to that, they have the bacteroides, which is an anaerobic organism. The clinical features of cholangitis, okay, as I told, is Charcot triad of right upper quadrant pain, fever, and chills, jaundice. And this fever is usually accompanied by chills and rigors. Then, of features of obstructive jaundice is another important clinical presentation, manifestation of ascending cholangitis, which include pruritus, generalized itching, pale stools, and dark urine. Then a history of gallstones is important, because once you know the patient has gallstone, the chances of getting cholangitis becomes much higher. Then recent biliary tract instrumentations such as the ERCP, cholecystectomies also can predispose to infection, and previous cholangitis. Okay, so it's important to get a history of gallstones, recent biliary tract instrumentations or biliary operations, and previous cholangitis. Medications including oral contraceptive pills and fibrates can increase the risk, and a lipid-rich diet may indicative of gallstone as a potential underlying cause. On examination, as I mentioned, patients are febrile, pyrexia in over 90% of cases, and this accompanied with rigors, jaundice, and right upper quadrant tenderness and pain. Patient may be confused, hypotensive, and tachycardia when they are going into the septicemic phase of the infection. As I mentioned, the two common eponym syndromes associated with the cholangitis are the Charcot triad and the Reynolds pentad, okay, which carry along with it the various symptoms of the condition. Okay, now a few words about ascending cholangitis. Ascending cholangitis, classically, as I said, produces the Charcot triad. This is a normal patient, not a very severely infected patient, with right hypochondrial pain, jaundice, fever, and chills. Okay. Now, if the disease is more severe, where in addition to the above triad, the patient may have pus in the biliary tree. Okay, and this is called acute suppurative cholangitis. When this develops, the patient becomes very ill and goes into septicemia. When this happens, two additional parameters may be observed in the patient, that is hypotension, systolic blood pressure of less than 100, and mental confusion. These patients are in the verge of going into shock, septicemic shock. They can be very disoriented, confused, or very drowsy. That is known as the Reynolds pentad. So Charcot triad, 3 parameters, Reynolds pentad, additional 2, hypotension and mental confusion, indicating it is a more severe form of septicemia compared to Charcot triad. Okay, differential diagnosis, as we saw in this patient. Okay, cholangitis is not a complete diagnosis. You must, as there's always an underlying cause which should be included in your diagnosis, because that should be identified and treated. So in this patient, the underlying cause is gallstone. So gallstone or CBD stone, okay, is the cause of the obstruction. So that is a full diagnosis. The clinical features of cholangitis are very similar to other biliary pathologies such as biliary colic, okay, which also carries along with it fever, leukocytosis, or jaundice. Okay, in simple biliary colic, you may not have fever, leukocytosis, or jaundice. But in septic cholecystitis, these features may accompany, but the jaundice may not be that severe. Cholecystitis will present with right hypochondral pain and fever, yet the jaundice may be absent or only mildly present, only at a mild degree. Investigations, the laboratory tests, routine blood tests, which I already mentioned in this patient. FPC will show leukocytosis. LFT will show raised ALP, okay, alkaline phosphatase, and GGT with raised bilirubin. Okay, this case that we discussed already demonstrated these signs. And what is important is to do blood culture. This must always be taken in suspected cases, okay, which may be positive in about 20% of cases. This will help us to give the most effective antibiotics against the organism that is being isolated. Next we come to investigation is an imaging. Ultrasound scan of the biliary tract will show bile duct dilatation. As in this case, it also shows a stone in the lower bile duct. The common bile duct is normally less than 6 millimeters in size. The size may vary in older patients or patients with previous surgeries. So any diameter larger than that suggests a dilated bile duct. And then you may have to do a ERCP, which is the gold standard investigation for cholangitis, is ERCP. So as long as you suspect cholangitis, features of cholangitis, the most important investigation is ERCP. Of course, it's after the ultrasound. ERCP is both diagnostic and therapeutic in this patient. Some endoscopies may require an MRCP prior to intervention. However, this may not be necessary in all the cases. We can go straight to do an ERCP. Okay, this is the picture I showed you all just now. This is the CBD dilated with two big stones in the lower end. Okay, and this is an ERCP picture showing two filling defects, okay, which are gallstones at the lower end of the CBD. And this patient will need urgent ERCP and sphincterectomy and extraction of the stones. Okay, management of the patient. This immediate management, as I mentioned earlier, patients with cholangitis may present with sepsis, so should be managed promptly and often with a high level of care and urgency. First, under the immediate management will be IV access and fluid resuscitation, okay, to ensure the fluid and electrolytes are in balance. Routine blood tests, which I've already mentioned earlier under the case discussion, and blood cultures must be taken early. As soon as the patient comes in, you suspect cholangitis, jaundice patient with fever, you must do a culture so that you can get the results and you can modify your antibiotics according to the culture report. Meanwhile, you must start them on broad spectrum antibiotics therapy, usually to cover the gram-negative organisms such as amaxiclav or broad spectrum cephalosporin plus metronidazole, as these will cover both the gram-negative and anaerobic bacteria. Definitive management will be biliary endoscopic decompression. This is the ERCP. And this must be done as an emergency intervention, and in many cases, if you do it early, it can save life. ERCP with or without sphincterotomy and stenting should clear any obstruction. This is the treatment of choice for all patients. In patients who may be too sick to tolerate ERCP, percutaneous transhepatic cholangiography or PTC can be used as a second line of intervention. But this investigation is becoming not so useful design because ERCP is far superior to it. In the long-term, patients may require cholecystectomy if gallstones are the underlying cause. This can be done with the ERCP if the patient is clinically stable and fit for the procedure, or it can be done as a elective procedure weeks later when the patient is more stable and his biliary tree has been decompressed adequately. Okay, the laparoscopic cholecystectomy will be the operation of choice. ERCP, must remember, has got some significant complications as well. Okay, significant complication of ERCP including repeated cholangitis. You can reintroduce bacteria to cause repeat cholangitis. It can cause pancreatitis in about 3 to 5% of patients. Bleeding, okay, especially when the sphincterotomy is done, higher chance of bleeding, and perforation of the bile duct, which is a rare complication, yet must be kept in mind, especially for urgent surgical intervention is required. What's the prognosis of cholangitis? The mortality of cholangitis is around 5 to 10%, which is a significant figure. And this is so in those patients who we have given adequate antibiotic therapy. Okay, but the therapy was started late. Early ERCP and early antibiotic therapy have both been found to improve the patient outcome, the prognosis. Factors which increase the mortality rate include delayed diagnosis. Very important. It's very important to diagnose early. Delayed diagnosis, comorbid illnesses like liver failure, cirrhosis of the liver, chronic kidney disease, hypotension, female patients, and those above 50 years of age, and more so patients with diabetes mellitus. These are all high-risk patients, and these patients, if the treatment is not started early and adequately, then the mortality rate among them may be high. Having said all this, now I come to give you the key points or summary of cholangitis. These are the following summary of the cholangitis. Cholangitis is most commonly caused by gallstone disease and is associated with high mortality. Patients will often present with right upper quadrant pain, jaundice, and fever, the so-called Charcot triad. Most cases should be initially investigated via ultrasound. Okay, in fact, all patients should be investigated by ultrasound these days. All right. Early IV antibiotic therapy is warranted, yet definitive treatment often comes via ERCP, which is done as soon as possible. As soon as the patient is fit for the procedures, it should be done within the first 48 to 72 hours. Okay, so these four are the take-home key points about cholangitis, which was clearly demonstrated by this patient, 41-year-old patient that we discussed just now. The following is a short video by Jürgen Paul of Horst Schmidt Clinic in Germany. It is on cholangitis, sphincterotomy, and stone removal with an extraction balloon.
This is an ERCP in a 72-year-old man with symptomatic cholangitis.